team, including surgeon and radiotherapist and oncologist. So we'll start first with the case presentation, and through this case, we'll stop at certain points to ask how to do. Mr. M is a male patient, 57 years old. He is hypertensive and not diabetic. His sister is under treatment of breast cancer. He was diagnosed in May 2007 because complaining of hematuria was silent, as having left side large renal mass, as shown here. SCT chest and bone scan was negative. So the first question to the panel, what is the proper management in this moment? We start with Dr. Kara.
I would do a metastatic workup just to check what the situation is. So the patient has no symptoms related to bone or neurological symptoms?
Yeah, SCT chest was free, bone scan is free, not complaining, just silent hematuria.
Okay, I mean, in general for hematuria, I would do a cystoscopy just to be sure. But assuming the patient's liver, kidney functions are good and has no metastatic disease, and he has 2 kidneys and this large tumor, I would recommend a left radical nephrectomy.
Yes, okay. The second question, as you mentioned here in your presentation, when to go for partial nephrectomy?
So in a patient who has 2 kidneys, who has good kidney function, and who has a 12-centimeter mass, this patient should not have a partial nephrectomy. This patient should have a radical nephrectomy.
Apart from this case, the indication guidelines, when to go for partial nephrectomy?
Well, the guidelines, most of them would say that the patient should have T1A, T1B, some selected T2s or T3s. The patient, the imperative indications are solitary kidney or 2 kidneys with poor renal function, that if you do a radical, the patient will end up on dialysis. Now there are phase 3 trials, level 1 data that says partial and radical are equivalent, but even the first author of that study still, when he goes and presents the study, says he still does partial nephrectomy whenever he can. So the guidelines tell us do a partial nephrectomy whenever it's possible technically to do it safely.
Yeah, okay. What do you mean by safety? Is it safe, like will compromise the outcome of the patient on the long term, or just safely, as you mentioned, as related to comorbidities?
Mostly safely that the goal is to not leave any cancer behind. So if you're doing a partial nephrectomy and leaving tumor behind, that's not a safe operation. So if you can guarantee negative margins and the patient needs to have partial nephrectomy, then that's what we want. As far as safety from surgery, for people who do these surgeries on a frequent basis, a partial nephrectomy should be a safe operation for the vast majority of patients. So, but for this particular patient, I would not do partial nephrectomy unless you show me some other pictures that.
Sure. As regards the agent, Dr. Hassan, what's your opinion? Is there any experience in partial nephrectomy and Mansoura Center?
Yes, it is.
Yeah. Here?
I think the surgery depends on many factors, not necessarily the size of the tumor, but also the capability of the surgery.
So now the solution is you have to do a partial nephrectomy if even the patient has 2 kidneys and the tumor is less than 4 centimeters. But nowadays it has been changing. We are now more liberal in doing more partial nephrectomy, even if he has the contralateral kidney is normal. So as long as you can remove the tumor safely, as regard the intraoperative comorbidity, not leaving behind the tumor tissue with good safety margin, I think you have to leave behind the maximum amount of healthy nephrons for the sake of the patient. Sometimes there is some strict indications like solitary kidney, like patient with diabetes or in a high-risk disease of compromised kidney function, you have to exhaust yourself to do more partial nephrectomy, more liberal than you have to take. But in case like this one, I think the tumor, if you don't show us another pictures to see how much healthy kidney tissue is remaining behind, and so long as the patient has the other contralateral kidney is normal, so we proceed immediately for radical nephrectomy for this side, leaving him an intact kidney.
So,
please, Dr. Mahmoud, نسيت أعدل.
Please, Professor Hassan, please you are with us. For such a case with hematuria and cystoscopy is free, is there is possibility of infiltration of the renal platelet, so it is absolute right for radical nephrectomy?
No, this is not the rule. If you can,
For such a case,
even yes, even you can resect half of the kidney with some pelvic calcium system in, provided that you clean all things, so you can do that. Hematuria is not an indication of radical nephrectomy as a single indication.
infiltration of the renal platelet.
Yes?
yeah, the second most important point and raise the issue nowadays is the local ablative measures used nowadays, but we don't know exactly or more about this. What's your opinion regarding the local ablative methods? I mean, embolization, radiofrequency. Anybody had any experience like
Just a moment. I think this is a bit further. The decision for partial nephrectomy, is it sometimes you can see tumor growth to 10-12 centimeters diameter, but still with the good remaining, good healthy tissue. Would this affect our opinion for partial nephrectomy?
No, I mean, we, like Dr. Al-Rani said, the indications now have stretched. Initially, everybody said, only T1A, 4 centimeters or less. But there are several, again, they're all retrospective studies, but several retrospective studies comparing partial nephrectomy in T2 and T3A, comparing them to radical nephrectomy with equivalent outcomes. Now, of course, retrospective, small, selection bias, but if it's technically doable, we can do it, but the question is how much benefit, that's what you have to individualize, how much benefit you're giving the patient by subjecting to a hemianephrectomy, or are you leaving enough kidney tissue for it to be alive? I've done partial nephrectomies for tumors as large as 19 centimeters, but that because the patient needed it. I don't do that every day, but the patient needed that, we can do it. But just because we can do something doesn't mean we always have to do it.
Because this is the point. I mean, it looks technically appealing. I mean, the tumor looks resectable with partial nephrectomy and the good remaining part of the normal kidney tissue. This is rather inviting to go for a partial nephrectomy. But should we do that? I believe not.
If the patient needs it,
yes. And if the patient is really in need to have this. Now, the second question will come up.
Yeah, the second question regarding
just does the genetic testing affect the partial nephrectomy if the patient has a mutation or they are at high risk of having a recurrent disease? Does this help you taking a decision whether to go for
Genetic testing for what, BAC1 or, no, I mean, then we're talking about biology. Now, if I do a partial nephrectomy or a radical nephrectomy and get negative margins with either, the tumor is going to do whatever it's going to do. So as long as I can get negative margins, whether it's partial or radical nephrectomy, if they have a BAC1 mutation, which happens in 10% of patients, they're going to have a poor outcome regardless, and they're going to die from metastatic disease, not from local recurrence. But we don't test for that in these patients before surgery, and there hasn't been any studies that has tested that just to tell us if we do a radical or partial. I think these patients, if they're going to die, they're not going to die if I do a partial or radical. They're going to die because they're going to have liver, bone, lung mets. So there are no molecular testing now that should guide us whether we should do radical or partial nephrectomy.
Yeah, recently raised the issue about local ablative measures for renal cancer. What about India? There's some experience regarding this, and what's possible indication for such?
So in general, we have a very good relationship with our interventional radiologists. So the things I will tell you is we have several dozen urologists and radiation interventional radiologists. There's only 2 interventional radiologists that do renal ablation. So there are more than 20 radiologists, but only 2 of them do it. So all the ablations are done by 2 specialized people only. So if they're on vacation, the patient will wait until they come back to do it. So that's how we try to keep it specialized so we have the best experts doing it. So in general, we do it when the tumor is 3 centimeters or less. It can be done in bigger tumors. The Mayo Clinic group has published on larger tumors with cryoablation. If we have to do it for bigger tumors, usually they will do selective embolization of the tumor before doing cryoablation to decrease the chance of bleeding from cracking the ice ball. The patients who do that, who we recommend for ablation, are patients who in general are old.
This is the important point.
Yes, they're older patients, sicker patients who refuse to have active surveillance. So I have an 88-year-old patient that I saw 2 weeks ago that wanted something to be done. I tried to convince him for surveillance, which I think is the best thing for him, but he was adamant he wanted to have something done. So we referred him for ablation.
So if I can do surgery, you should plan to go for surgery.
Yes,
Yeah.
yes, definitely. That's what we recommend. And even our radiologists, if I send them a 40-year-old patient with a small tumor for ablation, which I haven't done, but if I do that, they will call me and ask me why, what's wrong with the patient, why he should have surgery. So in general, we do surgery for younger patients just because we know very long outcomes for partial nephrectomy. And just as the guidelines say, and again, they're guidelines, they reserve the ablation therapy for sick, older patients, which a lot of them can also qualify for active surveillance.
So, the patient underwent left nephrectomy in 2007, and the pathology came as clear cell renal cell carcinoma invading the renal capsule, extending to the renal vein. There is many vascular emboli. The margin was negative. It was T3N0, M0. As I mentioned before, bone scan was free. CT chest showed mild left pleural effusion, which was attributed to Beery actually post-operatively. So, after curative surgery, is there any role of adjuvant treatment? The panel, oncologists?
The data is negative for adjuvant treatment, so there is no adjuvant treatment.
Even in the era of targeted agents?
No recommendation.
Even for the targeted agents.
Yes, yes. So, okay, the recent published data regarding targeted agent was negative. By the way, about local treatment like radiation treatment, Dr. Ahmed?
Yes, there is a infiltration of the capsule, but the renal cell carcinoma is called the undiscovered undiscovered area of post-operative therapy, because most of the literature does not support adjuvant therapy in this setting. But sometimes selection of cases and discussion with the surgeon may select some cases, particularly in the left side, because this patient was in the left side, away from the liver. The toxicity would not be very great because the dose of radiation applied 45 to 50 grays. So some selected cases with discussion with surgery might be benefited from radiotherapy. I remember a case last week we found in the clinic. The patient underwent partial nephrectomy and came back after partial nephrectomy 3 years ago, and came back to our clinic last visit by local infiltration of the chest wall. So we cannot ignore the role of radiotherapy completely, but this should be given on selected cases.
Yeah, I do agree with Dr. Ahmed, but in the guidelines, when you have negative margins for radical surgery for RCC nowadays, there is no consistency as regards post-operative radiotherapy. In the past year, adjuvant radiation therapy was approved. By nowadays, or a few years ago, it's not approved for patients having radical surgery and negative margins, unless there is special situations.
Yeah, it's negative margin, and I think the old data also recommend against given local treatment, and despite of this, the treating physician at the time decided to give the patient post-operative radiotherapy, and the patient finished without toxicity and was put under follow-up. So, in 2012, the patient developed dyspnea and pain in his left loin. CT chest showed moderate to marked pleural effusion and local recurrence. Cytology was taken and was positive for recurrent renal cell carcinoma. SLDH, hemoglobin, and serum calcium were within normal range. So, the decision for the panel. What is the next step? Dr. Jafar?
This infusion was positive for the
Yeah.
Cytology is positive.
that
And this
patient
is-
is
yeah.
metastatic disease, and he has to go for targeted therapy if the patient is fit. So,
On the workup, is the only side, the local recurrence and
Yes, this is the CT. This is the only positive side. Just
if the patient has the full scan or PET-CT or
no. At that time it was 2012. It was not available.
Would you elaborate, Professor Sam, why you are asking this?
so this is important.
yeah, we have to know the baseline and the extent of our
How many
disease
metastatic
and how
sites?
many sites of metastasis.
This is the only positive side. Pleural effusion, local recurrence,
Actually, by
and another
2012 there was
medical.
a PET-CT initiative.
But even if there was,
It was 2012.
just to be the devil's advocate, this PET-CT recommended for kidney cancer.
Yeah, but I mean, for searching for other metastases.
I would just do CT scan. We've never used PET scans for this.
Don't use it as a standard of care.
Yes.
But we are searching for other sites. If the patient did not have a full scan, we don't know if she had bombinus or not. So we are asking to have the data about the size of metastasis.
Yeah, this is by CT the only three sites. Just left-sided moderate to marked pleural effusion and two local lesions as you see, local and one above the diaphragm. So,
But why you did comment on the initial phase of pleural effusion shortly post-operative, and you just rely this on not on a residual tumor, or it's only surgical reaction from the operation?
yeah, because in frequent follow-up later on it was resolved.
Resolved on
Yeah.
that.
It was resolved by frequent follow-up. So, the patient drained by chest tube, then went for first-line treatment. So, what model of prognostic classification you would follow? Because there is a lot. Question for all the panel, surgeon and oncologist. Because they are different.
Usually the pneumonia.
Which model you prefer?
I think there is no ideal model to monitor this patient, and in practicality, we are almost using the same treatment.
But you see this
But
probably
I think
difference.
for clinical trials, and in order to know the prognosis of that patient, it is important to categorize these patients accordingly.
Why I'm asking this? Because the model is not consistent between the trials and the base guideline every now and then, but for different criteria of the patient. So for this I'm asking. The patient was classified by the Memorial Sloan Kettering Cancer Center as favorable risk, as I mentioned before. So in case of metastatic disease in such case, which group of patient will benefit from surgery if his kidney is still in place? Surgery.
So you're talking patients who have a kidney in place with
Presented
synchronous
first.
metastatic disease.
Yeah.
You're gonna make me give my talk today then. So the patients I would do
Just in
surgery
summary,
for.
just in summary.
So it'll be young patients, usually clear cell histology, intermediate or favorable risk patients in general. We have our own criteria at Anderson that we've published, and I'll give them more detail tomorrow. And patients who have a resectable tumor that's not a T4 tumor, because T4 patients, invading other organs in the setting of metastatic disease, their survival is about 4 months.
Symptoms.
Well, palliation, sometimes, but these medications that we have available now, they can help with palliation as well. So surgery has been, we've shown that it can palliate some patients in about 25% of the cases, but it's still a big operation, and if we can control the symptoms with embolization, which that's the only reason we do embolization nowadays in our center, or with targeted therapy, we will in general proceed with that.
Yeah, you can do it with any risk subtype of the patient, either favorable or low risk?
Well, the risk criteria, they're not designed to tell us who we should do surgery for or not. The risk criteria are patients who've had surgery who are getting targeted therapy. So these risk criteria, they're not, a lot of people use them for the wrong reason. They're not designed to tell us who should have surgery and who should not have surgery. So I don't think we should use these specific criteria to tell us if it's low risk, we should never do surgery on that patient. So we have to individualize that. I'll show you tomorrow different criteria that we use. And one thing with poor risk patients, what we've been doing now is we've been giving them targeted therapy at diagnosis, and then just like our pre-surgical trial, and then go ahead and see if their performance status improves. If they change from poor risk to intermediate risk, then we'll go ahead and do surgery. So we're just delaying surgery for a short time to see how they respond to therapy.
Dr. Saleh, may I ask you, your decision for your patients as regards surgery for this specific patient?
It was...
Because it's a case here, we are taking...
I'm not
to lose
the
the line. Yeah, what about this case, about the patient?
During the course of the disease, I raised this issue because we raised with some surgeon this issue about local treatment for such metastatic cases.
What you have local recurrence and you have malignant pleural effusion.
Yeah, we did.
But do they have local recurrence? This is a metastatic disease into the pleural cavity. This
Yeah,
is not a true local recurrence.
He had local recurrence and
Pleural effusion.
Your patient.
Yeah.
The first case, you said that he presented in the year 2012 with later, after 5 years after surgery, he presented with malignant pleural effusion,
Yes.
as well as local recurrence.
2 lesions.
2 lesions, yeah. So, the decision taken for this patient as regards surgery was to go for surgery?
Just palliative chest tube, no surgery. My question is not related to this. In case of intact kidney, the patient first presentation with metastatic disease, what the role of nephrectomy away from this case?
I know. Okay, so this was the Professor Karam presentation today, but we have a discussion. Then we have to know the impact on the model you have put the patient for. Does this patient, you think, if nowadays you are taking the decision, would benefit from surgery after this discussion or not?
If he has intact kidney?
This patient?
No. We did not consider surgery at that time. Because not the local recurrence or the lesion of the diaphragm, but because of the effusion. Yeah.
Okay,
so
because we have only 5 minutes. We escaped the time is up.
Yeah, okay.
We have one question in the back.
Question coming from the back.
Please. Can we have a mic over there? Microphone? Can't hear.
You mentioned a sister under treatment of breast cancer.
Yes.
Is there a relation between the management and the outcome of the disease for this patient with his sister has breast cancer?
I give the answer for the panel, but for my knowledge, if the question again, if the positive family history will affect the impact of treatment in this case, because of positive family history.
This is for you, Dr. Salem, because you highlighted the point, and I think you think there is a relation between history of breast cancer, one patient, and the development of RCC in a second or family?
Might not.
Are there any data supporting this assumption?
Up to my knowledge, no.
So
that's
why we is asking the correlations between. It's not it's not known that breast cancer had the higher incidence or as ovarian cancer or second breast cancer. There's no high risk in the family. If one having breast cancer and the second one developing RCC, unless there is some families where cancer runs in the families. But this develops that you should have at least more than one sister or aunt with breast cancer. Because he is asking about if there is genetical problems or genetical profiling was done for this patient. Is there any genetical profile was done?
No. We haven't. And I think no need to do this because it is just 2 cases and different diseases, and nothing in the literature support to do genetic analysis. Can I have something, please?
Do you think if another member of the family has some sort of other malignancy, and I'm treating patient with prostate cancer or kidney cancer or whatever it is, so I would add more restriction and more aggressive treatment if because his sister has breast cancer or colon cancer? No data to support this issue, because I think what you put it in the history to just make more exciting that it may be related that this malignancy run in the family. So that's
Sometimes, yes,
sometimes.
I have a problem here.
However, we would like to thank everybody here because we are 10 minutes beyond time, and we thank Professor Stalin for moderating this interesting session, and we invite Pfizer people to come here for the event. Thank you. Thanks everybody. Time to start our urogenital session, starting the MDT in cancer management, and I have the honor to introduce first speaker, Professor Hassan Abalanin, Professor of Surgical Oncology at Mansoura Cancer Center, and he is going to talk to us about bladder cancer in Egypt as regards the history and the future.
Thank you very much. Good afternoon, everybody. I hope that still you have some energy to follow me. And I am a urologist, neurosurgeon, working in urology and the nephrology center. And we are mostly dealing with oncological cases of urinary system, including from the suprarenal down to cancer of venous. And my topic for today in this nice conference is about the treatment of invasive bladder cancer, what we are doing now and what would be the future after that. I have to admit that treatment of invasive bladder cancer in the meantime is usually under treatment of this disease, because this disease is very aggressive, and whatever we are doing during the last 40 or 50 years, since Professor Essebai was doing marvelous surgical treatment of invasive bladder cancer, but I feel that we are still under-treating this disease. And so far, radical cystectomy is the gold standard of treatment of invasive bladder cancer. And we know from the basic knowledge that the radical surgery includes to remove about 9 structures around the bladder, including the prostate, the peritoneum, seminal vesicles, pelvic part of the uterus and vas, and the true and false ligaments of the bladder, as well as lymph nodes. The objectives here of the treatment of invasive cancer that we have to ensure radicality, and of course to maintain a good quality of life, keeping a good body image for urinary diversion, and to maintain continence as well as potency if possible to do that. Why radical cystectomy, the gold standard in the meantime? Because to our knowledge, it provides the best outcome compared to other single modality treatment. It gives us accurate staging even for subsequent management or not. And of course, in cases of advanced disease with the locally invasive involvement of the lymph nodes, we have to treat 1/3 of these cases with abortive nodes would survive for 1 or 5 years. But here in Egypt, we have some changes in the trend. We have changes of the age and presentation. Maybe before the 1985, the average age in our material of invasive bladder cancer was around 44. But nowadays we reach up to 57. So the age of the patient is increasing year after year. The second issue also tumor cell type and time trend. We have significant decrease of squamous cell carcinoma. On the other hand, we have significant increase of transitional cell carcinoma. So nowadays we can say that we are more Western in relation to the type of the cell cancer in the bladder, and still the adenocarcinoma is a plateau around from 5 to 7% of most of the published series. This was in the formal time attributed to the prevalence of schistosomiasis, which was one of the important pre-malignant lesions of the chronic infestation of the bladders with several repeated infestation and some metaplastic changes. But nowadays, I think the bilharziasis has been controlled, at least in our country. This is the figure that show that from the 1935, when 50% of the Egyptian population was infected by schistosoma, and now with the year of 2007, we have 0.9% of the patients still have, in some pockets of the rural areas, still suffering from bilharziasis. So I can say now we cannot incriminate anymore the bilharziasis as a etiological factor of the prevalence of the tumors, as well as we have many changes of our cell pattern now. This is again now the relation between the bilharziasis and the development of bladder cancer. Of course, the intensity of infestation by bilharziasis occurs at the teen ages, but the cancer comes after 40 years of age, so there will be a latent period of some DNA changes and metaplastic pathological changes to develop cancer. These pictures we didn't see anymore in the significant calcification of the bladder wall, and sometimes this calcification is eaten by cancer, and it was pathognomonic in before the era of CT scan and MRI. It was only plain X-ray that we can diagnose cancer when the eating calcification of the bladder wall is apparent in the plain film. Even we can give it the Makar sign, which was one of the pathognomonic features of development of invasive bladder cancer. Again, in such cases with huge tumors and huge hydronephrosis, in the cases we don't see it anymore. Maybe 15 years or 20 years ago, we had most of the cases was very locally advanced with hydronephrosis on both sides. Again, such lesion which will, if we can see this lesion now, immediately we diagnose it as bladder cancer. But at that time, it was only bilharzia granuloma, and all these lesions which looks like invasive carcinoma of the urinary bladder, it is only granulomatous lesions and could be completely cured by anti-bilharzia treatment. When these lesions heals, it would be fibrocalcific polyp or sometimes villus polyp, and these findings is now rare occasions. Again, the contracted bladder and development of leukoplakia as some of the precancerous lesions of this bilharzia bladder doesn't exist anymore. But still we have a lot of huge size bladder tumors, significantly fungating tumors. If we compare these tumors in our locality, it's completely different than the Western pattern of transitional cell carcinoma. So our cystectomy cases usually came advanced and late presentation, and it usually represents some form of surgical challenge. Again, different cell types, including DCC and squamous carcinoma, as well as adenocarcinoma, and sometimes in 15% of cases we can have some differentiation, so mixed tumor is quite existing as well. Recently we did some research and looking for the relation between the bladder cancer and HCV. The hepatitis C virus now has been invited to come to Egypt instead of having bilharziasis. So fortunately enough we have treated schistosomiasis, but instead of that we have a new guest for the local disease here, which is the hepatitis C virus. We studied the hepatitis C virus. It has relation to the pattern of dissemination or the survival of bladder cancer, and of course we found it very interesting. In 1935, schistosoma was prevalent, but nowadays 20%. Roughly, I can say, of population in Egypt are infected by HCV, either active or inactive. In this study, we just compared the two groups of patients, 60 patients in every group, those who would have hepatitis C positive, and those who have no hepatitis C positive, negative for HCV, and we studied the tumor configuration as regard the tumor cell type, as regard the stage as well. We found that when the virus is there, the tumor grade is higher, the tumor stage is higher, the involvement of lymphovascular invasion is also higher, as well as the lymph node involvement. And this has been reflected after being treated in the same way of radical cystectomy and the urinary diversion. And we could isolate some gene expression in favor of that. When the virus is there, the tumor is more aggressive, and there may be correlation between the DNA changes and this gene effect on the survival of the patients with invasive bladder cancer. This is the survival, overall survival, it was in favor of negative HCD was much better. When the virus is there, the tumor will kill the patient much more rapidly than when it is not there. Even the disease-free survival was also negative. I don't know, we have now to isolate the virus from the tumor cell, to isolate the DNA of the virus from the normal tissue surrounding it, but we are looking for explanation why the patient who had hepatitis C positive did worse if compared to those who didn't have this disease. I think this is exhaustion of the immune system of the patient that make the tumor flourish rapidly and may be the reason of mortality in patients with exhausted immune system secondary to HCV. Again, further work is needed in this issue, and still the door is widely open for further genetic studies, DNA sequencing and microsatellite, and mapping of this gene system to compare between these two groups. Still, we have some problems in the presentation of our patients in Egypt. Most of these patients come from rural area. We have lack of medical insurance system. The health provider is still a little bit underestimated. Patients usually come late presentation associated with hepatic disease, maybe anemia and nutrition disorders, and many of these patients have either local high stage or low performance status. Whatever the wide resection by open surgery we do since the last 40 years, still we are treating roughly from 50 to 60% of patients. This is a series including several thousand of patients treated in the urology center in Mansoura, and still we have 5 years is around 55%, and 10 years 50% of patients are alive of disease. There is no correlation, no significant change if it is transitional or squamous adenoma, and usually the survival is the same and there is no significant change. But the grade did a difference. In low-grade disease we have around 75% survival, but in high-grade disease it can go down to 40% at 5 years. This is just to see some of the biggest series around the world that we are globally treating more than half of the patients, whatever the wide local resection. So still there is a significant problem of treatment of the invasive bladder cancer, and we have to look for an additional therapy or modify the treatment methods of this disease, as we will see in a minute. Again, some also of 10 years survival 27 when the disease has extra survival extension as reported by Steen from Los Angeles. Again, this disease is very aggressive and lethal disease, and we have also to be very aggressive as a physician of treatment of this aggressive disease. So we need an extended radical surgery plus or minus systemic therapy to cure such a disease. But on the other hand, recently we have what is called minimal invasive techniques. We can do minimal invasive techniques in doing benign tumors or benign lesions like cholecystectomy, like appendectomy, like whatever, but not for this aggressive lethal disease. We have to be more aggressive. But for the pressure of the industry to sell robots and to sell laparoscopy and that, they started to do bare hole surgery just to cut the areas of the tumor and not necessarily to come more